Hello. So welcome to the second day of the meeting. Again, I'm very sorry for not being there. My second talk is multimodal refractive imaging and Vadis. Vadis means what to expect for the future. So it's important to consider what we have today and trying to do to have predictions for the future. Those are my financial disclosures. And when you think about diagnostics for refractive surgery, again, it's with even the art of war, the wisdom in which we have to understand the enemy and ourselves so that we gain the battles. We have to think about the what's in the house. We are trying to optimize refractive surgery, optimize planning, optimize the results and efficiency and safety, preventing complications, and all of this will be important to understand what we have available in terms of diagnostic technologies from topography to tomography, segmental tomography, biomechanics, whole eye wavefront, axle length, all this data together. And more in the future, we believe, on genetics and molecular biology. And we'll just touch upon those concepts in this next 15 minutes. Those will be the hows. The multimodal imaging concept is not exclusive to cornea and to refractive surgery, actually goes much beyond the cornea in terms of refractive imaging, but we have to understand that this is really multimodal and a revolution in evolution. One of the aspects that have evolved tremendously is segmental layer or micro layer tomography. We have the role of epithelial thickness as we reviewed in 2017, part of Marcela Salomon's PhD thesis. We have a fellow eye with a very asymmetric ectasia, and you see some thinning here. The still limit to 6 millimeters. If we have 8 to 9 is much better. Now you have more subtle keratoconus, more advanced and more severe keratoconus, and you see the thickening, the thinning, and the thickening surrounding the thickening on the epithelial profile. And this is also going to be important for us to understand the effect of surgery as we do in intracorneal ring segments, and we'll discuss that later. OCT has tremendously evolved. We have different OCTs in the market. This is one of the OCTs that has multimodal imaging for retina, for macular optic nerve, but also for the anterior segment and also axial length. So you can get a lot of data from these measurements. And we are just starting to scratch the surface on the possible benefits and potential for those technologies. We have, of course, very high frequency ultrasound, and one of the applications that will be exclusive to those, because high frequency ultrasound can penetrate tissue, so can see behind the iris for improving the calculations and sizing of posterior chamber phakic IOL, which I believe will be a very important application for us in the future, as posterior chamber phakic IOLs are evolving very fast. We have the ICL with presbyopic approach. We have different posterior chamber phakic IOLs available today, and I predict that this will be a very important market for the future, and the application of sizing will be a very important one. Of course, characterizing lens dysfunction, multimodal imaging will give you whole eye wavefront, shine fluke data, and integrating all these technologies will be important for us. And this is something that we predicted. It is one of my first papers, a review paper published in 2001, when I started my fellowship with Steve Wilson, the role of corneal topography and the era of wavefront technology. A lot of people would say a misleading concept that wavefront technology would replace corneal topography, which is actually the opposite. It makes even topography more relevant because you can integrate data of front surface topography and whole eye wavefront and eventually tomography with whole eye wavefront. And this can be done with different machines. This is a patient that came with progressive astigmatism, and he was referred for keratoconus treatment for cross-linking. The colleague wrote cross-linking in his letter. I'm sending you this patient so that you consider keratoconus treatment. And please let me know if you're going to undergo to do cross-linking in this patient. And when you look at this patient with shine fluke tomography, you can see something very interesting here at the anterior chamber depth. This anterior chamber depth mapping. Actually, the cornea was thin. Very interesting because the cornea was thin. And the cornea was thin, but this patient, when you see the front surface topography. There's a barometry from surface topography, the whole eye barometry, and you see the internal. There is something much different than the cornea here. So if the cornea is the most important problem, you see more similar in whole eye wavefront than that, and you see that this is something on the Scheinflug. You can see the depth of the anterior chamber, but here you can see the centroids. There is something here, but when you see a dilated image of the lens, it's unquestionable that this patient doesn't need cross-linking in the cornea, maybe cross-linking in the lens. And it's very subtle. The patient is starting to have sublux lens, and this is related to Marfan syndrome. Another case that had presenting with mild cataract, patient 72 years old with 20/30 distance correct vision, and she was not bothered by cataract too much, and she was probably going to be happy asking with new glasses, which the wavefront data can help me for that, but I can use this data to look at the quality of her vision and to document the progression of the lens changes. But eventually, when I see something here, it can cause my attention. I see that in this cataract display, very nice work by Nikayuki Maeda, this patient has mild keratoconus, but also has some density in the back of the cornea. And this back of the cornea increased density is related to guttae. And this is mild guttae that the patient has. So this patient does not have subclinical edema, but unquestionably has like a weaker endothelium. So it's a combination of corneal guttae and keratoconus, and we have to be aware of the signs of subclinical edema. Very nice work led by Dr. Patel from the Mayo Clinic in the United States, looking at the three signs: the displacement of the thinnest point outside the temporal towards the nasal or superior, the loss of the isopax, and a focal area of depression. And the only thing here, I don't like this scale because I really like to see this blue in terms of red, this blue and blue for looking at edema, and red and red when you think about ectasia. So this scale for elevation is, in my opinion, not very proper. But this report, this very nice study, lead us to the commentary in ophthalmology. This is the Scheinflug camel sign, which is related to the density in the Scheinflug imaging. But in the OCT, this can be seen as a very important sign of the guttae that is not so good. So guttae can appear in some cases that is not very harmful, and you see guttae very stable for many years. But when you see a very thick endothelial complex, this is a more less good prognosis, and you see the blue and blue here on the pachymetry map and the posterior elevation maps, and you can see in both eyes, and also a horizontalization of the thickness profile. So this patient has mild guttae. And of course, the association of keratoconus and guttae is important. Another concept is that we should screen for ectatic disease prior to refractive cataract surgery, especially when you think about multifocal intraocular lens, because about 1 to 7% of cases on the cataract domain may present with subclinical keratoconus. And this was very nicely seen by Shizuka Ko in this letter to the JCRS last year. And she really looked at the importance of having more sophisticated data with including tomography and biomechanics for the detection. Of course, you have to still look at the surface, and this patient comes with a warpage, and you cannot say it's a warpage based on front surface topography. And of course, but the relevant here is that this patient is intolerant to contact lens due to her tear film, and the tear film can be seen in the non-invasive breakup time from the Placido disc, the keratograph 5M, and also you can see the deterioration of visual quality with the point spread function work, and very nice for the vision metrics with the Roger Zaldivar work. And also you can see the correlation of this slit lamp by microscopy of the lens. I asked my colleagues to show me the lens. They point here but the glands are here. When you see this, you start training your eye to look at this in a diffuse illumination. You can see the meibomian glands very nicely. So multimodal imaging goes much beyond detection of keratoconus, and of course, tear dysfunction is a very important part of our work. The combination of tomography and biomechanics. Of course, biomechanics is going to be important for specificity. And this is a patient that was also referred for cross-linking after PRK. And if you change the scale, you see progressive stiffening. Actually, the patient had progressive documentation of stiffening here, but this is not related to changes in the back of the cornea. And if you see the post-LVC, very nice work by Ricardo Vinciguerra for the CBI from the Corvis, so that you improve the algorithm for detection of post-laser vision correction that are stable compared to the ectasia cases. This is not ectasia. So the patient has, in fact, haze, and cross-linking is even not indicated. For looking at the biomechanical structure of the cornea, the biomechanical susceptibility, so that we can use this data for judging if LASIK and SMILE will be possible, considering also the level of correction, if the surface ablation is the best option, or phakic IOL, even if the patient has a therapeutic need in terms of refractive surgery. Interestingly, this can be seen retrospectively in some cases that we have data, but this is the fellow one-operated eye of a patient that developed ectasia. And you can see that the patient would qualify for LASIK based on topography and central corneal thickness. But when you look at the D, you have a little bit of the borderline value. Actually published that about 10 years ago. But when you see the biomechanical structure of the cornea, along with tomography and biomechanics, you see the TBI of 0.78. And this is important. Subclinical keratoconus can occur in both eyes of the same patient. That's the best example I can get to you. This is a twin sister, identical twins, front surface topometric from Placido and from Scheinflug. The fellow twin, both eyes have normal. The first twin is a very symmetric ectasia. All the four eyes have the TBI that is abnormal. Very interestingly, we had genetic profile from this patient. They first confirmed they are twins, which is kind of a joke because it was very hard work for me to get the consent, get this data, really smuggler that to the United States doing an AAO meeting so that the Evolino could do the analysis. But interestingly, they had a very nice profile for the Avagen for keratoconus, which really identified some genes that are related to genetic predisposition for ectasia. Of course, we need more validation on that, but there's a huge horizon for that. It goes in agreement with the concept from my colleague and friend, Dr. Rohit Shetty and his group from Bangalore, India, in which we have the lysyl oxidase concept that the deregulation of collagen levels of the fibromatory enzyme, lysyl oxidase, is related to the pathophysiologic approach of keratoconus. And this can be eventually seen in a patient that had ectasia after SMILE. He saved the lenticle, he froze the lenticle, he does it routinely. And eventually, when he looked at the lenticle of this case of ectasia after SMILE, he had a reduced LOX compared to standard control groups. When you look at the data of tomography and biomechanics, we don't have a final answer. And knowing enough to think we're right is a very dangerous thing, because eventually you don't know enough to know you're wrong, but we have to know that we have to know more. That's kind of my idea. So the recent TBI studies looked at the ROCs that were not the same as the first result, and we had the opportunity to evolve a revolution in evolution related to keratoconus diagnosis and artificial intelligence. So in a multi-center study, going from less than 100 to over 550 very asymmetric normal topography cases, we really were able to improve with artificial intelligence an optimization with different approaches. And we also get the random forest approach, and we had many ones, and we still can see even a better separation from the normal versus clinical ectasia compared to the first TBI. And we also improved from 75 to 84.4% with a better cutoff value. So it's something that is going to be more and more explored soon once it's available on the commercial software. And I really look forward to more external validations for the TBI and eventually further improving that, not only with tomography and biomechanics, but also with epithelial thickness data. So multimodal imaging is understanding the questions you have for the diagnostics, understanding the integration of data, the clinical concepts, again, artificial intelligence applied along with ancient intelligence philosophy. This is going to be important for customized treatments, individualized medicine, of course, doing humanized medicine with patient education. This data is very helpful for patient education as well, doing the best for helping the patient in the best way as possible as part of our mission as doctors. So thank you very much again for your kind attention. I really look forward to collaborating with you soon. Thank you.